who teaches doctors how to confidently assess and treat sleep issues without needing a sleep fellowship. She is a triple board certified physician in psychiatry, sleep medicine, and integrative medicine, with a passion for translating complex sleep science into practical tools clinicians can use immediately. Dr. Bhopal graduated from University College Cork School of Medicine, completed a psychiatric residency at Henry Ford Hospital, and a fellowship in sleep medicine at Harvard Medical School. A certified integrative psychiatry provider, she has taken additional courses in Ayurveda and functional medicine. After years of running a successful integrative psychiatry practice, Dr. Bhopal now focuses on helping other clinicians expand their clinical impact and income by adding sleep care to their toolbox. She's the founder of IntraBalance, an education platform offering online programs for physicians and therapists, including the Clinical Sleep Kit, a membership that helps users build confidence and competence in clinical sleep medicine, and other online programs and workshops. Dr. Bhopal shares clinical pearls and case based strategies on her YouTube channel to help doctors simplify sleep assessments, understand circadian rhythm science, and apply tools like CBT-i, ACT, and integrative medicine in real world settings. Um, with no delay, let me give the stage to Dr. Bhopal. Welcome.
Thank you so much. I'm really delighted to be here today, and it's actually perfect timing because today is World Sleep Day. So, what better day to be speaking about sleep health? And we'll be talking about that in the context of women's sleep health. Okay, so let me I'm going to just rearrange my screen a little bit and we'll get started. Okay, so why does women's sleep need more attention? Well, women are just more complex. When it comes to sleep, there's hormonal complexity. There's big research gaps when it comes to women's sleep health and understanding how women's sleep looks different. So we're going to talk a little bit about that today. Women also have a higher prevalence of specific sleep disorders like insomnia, restless leg syndrome. We're going to be looking at those as well today. Sleep apnea also shows up very differently in women than it does in men. And that's, if you take away one thing from today's talk, I want you to remember that, especially if you're working with women who have sleep issues. And the consequences of poor sleep is just broader in women. We're going to look at that as well. So the mental health impact is broader, but the cardiovascular sequelae, the physical health consequences of poor sleep is also larger in women. So sleep is super fundamental, yet we just don't have a good understanding yet of women's sleep health. Thankfully, that is starting to change as we have more women sleep doctors out there and more research being done around this. Okay. So here's where we're going today. We're going to look at what normal sleep looks like in women. We'll look at some of the sleep changes through the lifespan. We're going to discuss some of the common sleep disorders that you will see in women. We're going to touch very briefly on lab testing and some clinical pearls. And then we'll wrap up with how to think about sleep complaints in women. And as we start, I would like you to think about maybe a patient or a client that you're working with who is struggling with sleep. And by the end of this, you should have some um, more of a framework or some pearls to take away that you can use with that patient. And I'd love everyone to share in the chat, if you're here live, how many of you work with women who have sleep issues? You can just tell us in the chat there. You can put yes or no or all the time. I'd love to hear from you. And I see some answers coming in. I see a yes there. Yeah, very common. Anyone else working with women who have sleep issues, please feel free to share that. I see very often. Okay, and feel free to continue in the chat there. So I just wanted to start by looking at the research gap. So a lot of the re sleep research that we have currently has been done in men. So even the AHI criteria, which is the sleep apnea criteria, is based on research studies in men. Um, sleep res research rarely accounts for hormonal transitions in women. Most of the data that we have is cross-sectional. It's self-reported data. It's not necessarily age specific, so it's not taking into account those hormonal changes across the lifespan. And then we also have a lack of guidelines around different stages of life. So around managing sleep in pregnancy, managing sleep in menopause, and so on. So as you can see, there is a huge gap when it comes to the research. So why that's important is that sometimes the clinical guidelines that we have or the criteria that we have for diagnosing different sleep disorders don't quite apply to women. So we do need to think outside the box a little bit when we're working with women who have sleep issues. So this research gap also leads to delays in treatment. So we can get delayed recognition of true insomnia, sleep apnea, restless leg syndrome. We're going to talk about those a little bit later. As I mentioned earlier, women have a higher risk of depression, of cognitive decline, of cardiovascular sequelae when they have poor sleep compared to men. And so that's interesting. We'll look at that when we talk about sleep apnea. And then these health disparities result in underserved um, populations having worsening health issues. Okay, so let's look at what sleep looks like. This is normal sleep architecture. Are all of you familiar with the hypnogram? You can tell me in the chat yes or no if you're familiar with this. If you're not super familiar, I can explain it, but if you already know it, then we'll move along. And so I'm just looking at the chat there, and I apologize, I'm recovering from a cold, so if you hear me sniffling and sounding a bit congested, that's why. Is everybody familiar with the hypnogram? And if not, I'll take a moment to explain it. Okay, great. So this is a representation of sleep architecture across the night. So this explains, or this represents the different sleep stages and how they progress across the nighttime. So here's hour 0, and then here's hour 7. And so it kind of looks like a skyline. It looks like a city skyscraper skyline, right? And what we can see represented is at the top, we've got awake. These bars here, these represent REM sleep. And what you may notice is that the REM periods are shorter in the first half of the night, and then they get longer and more concentrated in the second half of the night. This is N1, that's stage 1 sleep. That's your transitional stage of sleep, where you're transitioning from wake to sleep. This is stage 2, which is still a light stage of sleep, but a little bit deeper than N1. And then N3 is deep, slow wave sleep. So when we refer to deep sleep, we're referring to N3, stage 3 sleep. What you'll notice with the stage 3 sleep is that it's more concentrated and you have longer periods in the first half of the night. And then those periods get shorter as the night goes on, and then you get more REM sleep. Okay, so why is this important to know? Well, first of all, our sleep does follow this specific pattern. So when patients ask you, is it more important to get REM sleep or more important to get deep sleep? We actually need all of those stages, and we need them in this specific type of order for healthy sleep architecture. So all the sleep stages are important, just like in a symphony. You've got all these different instruments, they're all important. The other thing I wanted to point out here is, do you see these little blips here where these go all the way to the top? These are awakenings. And what do you notice? There's a couple of them. And you might actually see more of them in your patients. These awakenings are completely normal. So this is an important thing for myth busting, that it is normal to wake up a couple times, maybe even 3 or 4 times across the night. And then they last a few minutes, and you can see, that it's lasting a few minutes, and then the person goes back to sleep. Those are completely normal and thought to be a safety mechanism. Because if we were out cold all night and there was a fire happening or there were intruders in the village or things like this, it wouldn't be safe. So we actually wake up in the middle of the night, survey our surroundings for safety, and go back to sleep. Okay, so I just wanted to give you that lay of the land. Now, when it comes to women's sleep, this was an analysis of the Oura Ring, the wearable tracker, and they looked at 45,000 of their members between 2023 and 2024. And the question was, do women need more sleep? And here's what they found. Women tend to need slightly more sleep than men on average. So they found that women were getting about 7.2 hours versus men getting about 6.8. They also found that women were more likely to have a shorter circadian rhythm, so that resulted in women being more of a morning person versus a night owl. They did find that hormonal fluctuations across the different stages of life, so menstrual cycle, pregnancy, menopause, increased the need for sleep. Now, do women actually need more sleep, or is it that they have poorer sleep quality from hormonal shifts, resulting in extended sleep time to compensate? That has still yet to be determined, but that would make sense, right? So, if people ask you, do women need more sleep? Well, maybe a little bit, but that may be because of these sleep disruptions from hormonal shifts and other psychosocial shifts that are a little bit outside of today's scope, but women are often the caretakers. They are often, taking care of things around the house and they're working, and there's just a lot more emotional load. There's a lot more of a burden with caretaking and other demands as well, right? So that can also increase stress and influence sleep issues. So as you can see, sleep is multifactorial. Now, when it comes to insomnia, insomnia in women is often a signal. It's not the diagnosis. Okay, so let's talk about what I mean by that. When you have a woman who is struggling with insomnia, we don't want to take that at face value. We want to evaluate the other factors that may be at play and other sleep issues that may be masquerading as insomnia. One of those factors we want to take into account is hormonal effects on sleep. So, progesterone at a very high level has sedative and anxiolytic features, so it's calming and sedating. It also acts as a respiratory stimulant. So what that means is that it can help open up the airway tone. So it prevents collapse of the airways. And centrally, in the central nervous system, it may also stimulate breathing centers. It's also been used to treat mild obstructive sleep apnea for that reason. Now, estrogen's effects on sleep are complex. So it's associated with metabolism of different neurotransmitters that affect sleep and mood, like serotonin. Estrogen also has thermoregulatory effects where it can regulate core body temperature. And that has an impact on vasomotor symptoms in perimenopause and menopause. We also need a reduction in core body temperature by about 1 to 2 degrees Fahrenheit in order to fall asleep and stay asleep. So if your body's too hot because of changes in estrogen, it's harder to fall asleep and maintain it. Now, I mentioned earlier that sleep deprivation hits women harder. So when women are sleep deprived, they tend to have more pronounced mood symptoms like anxiety, irritability, and depression compared to men. There's a larger impact on emotional regulation and executive functioning, like thinking, planning, focus. There's also a higher rate of depression, metabolic dysfunction, reproductive issues, cardiovascular disease, and cognitive decline in your women with sleep issues. So again, this is why it's so important to not only be identifying those sleep issues in your female patients, but also knowing how to assess them properly. Because one of the mistakes that I often see in clinical practice is that the workup, so it goes symptoms, workup, treatment, right? The workup, that middle piece is often missed. So I see this a lot where a woman will come in with symptoms of sleep issues and their physician or their clinician that they're working with may jump straight to the treatments. Okay, let's figure out how to get you sedated at night so you can sleep or give you something to help you stay asleep where that workup is missed. So I really want to emphasize that thorough workup so you know what we're dealing with. And we're going to talk about how to do that today. Now, just at a very high level, these are some of the sleep disorders that you'll see during different stages of a woman's life. So during the reproductive years, insomnia is more common, especially during the PMS, premenstrual period. And these are some of the changes in sleep architecture that you'll see. In the interest of time, I'm not going to read through all of these, but I think you'll get a copy of this to look at later. During pregnancy, you're going to see an increased rate of restless leg syndrome and obstructive sleep apnea. So those are two things that I really want you to look out for in your patients going through pregnancy. During menopause, we do see an increase in insomnia, especially after menopause, but there's also an increased prevalence of sleep disordered breathing, so sleep apnea. And that doubles, the prevalence doubles after menopause. So if you're working with a woman who is experiencing perimenopause or menopause, and she's struggling with sleep, especially sleep maintenance, One of the mistakes I see is that it's often attributed to hormones, and let's just give you some progesterone or some hormone therapy, and that should take care of it. But that sleep apnea is often missed. And last year, I saw 4 patients referred to me for treatment-resistant insomnia, 4 women, all in this perimenopause, menopause period, and they had tried all the usual things for insomnia. And I did sleep studies on all of them. They all had moderate to severe sleep apnea because sleep apnea looks different in women. So we're going to talk about that as well. But I want you to be thinking about sleep apnea in your female population, even when they don't have the classic symptoms that many of us were taught to identify. All right, so let's go a little deeper into those common sleep disorders. So we're going to talk a little bit more about insomnia, a bit more about obstructive sleep apnea, and then we'll touch on restless leg syndrome as well. And I'm curious, how many of you are screening for these sleep disorders in your practice? Are you seeing insomnia, obstructive sleep apnea, and restless leg syndrome? Tell me in the chat if you are seeing these and screening for them. So insomnia is more common in women. Women are 40% more likely to experience insomnia compared to men. And that could be because of those hormonal shifts that we talked about. It could be because women have a higher um, rate of mental health issues like anxiety and depression. It could be because of the caregiving and caretaking burden that we spoke about, and also some of the other psychosocial stressors that we looked at as well, leading to just an increased rate of stress. So there's lots of different reasons why women experience insomnia more frequently. Now, CBT-i is first line. CBT-i is cognitive behavioral therapy for insomnia. Are any of you using CBT-i with your patients? You let me know in the comments there. So CBT-i is really interesting because it is a behavioral-based therapy. It is non-pharmacological. It is the first line gold standard therapy recommended by the American Academy of Sleep Medicine for insomnia. And I see some of you are using it. Great. And what's really interesting about it is that it's also effective for hormonally linked insomnia. So if you've got a woman with those insomnia symptoms related to menstrual changes or related to pregnancy or that perimenopause and postmenopausal population, CBT-i works for that population. And I even hear from clinician colleagues skepticism about that, but this is based on the research. And um, randomized controlled trials in menopausal women show a decreased severity in insomnia when they do CBT-i. They also show increased sleep quality, decreased sleep latency. So sleep latency is how long it takes people to fall asleep. So they fall asleep faster when they do CBT-i, and increased sleep efficiency. Sleep efficiency is the percentage of time you're sleeping in the bed. And so you see an increase in that with CBT-i as well. And also, quite interestingly, you see a decreased impact of hot flashes, even if they're not experiencing a reduction in the frequency of those hot flashes. So they're still having the hot flashes, but the impact, the distance from those hot flashes, those vasomotor symptoms, decreases with CBT-i. So CBT-i is safe. It is a skill that your patients can learn. And as clinicians, great idea, learn some of those tools, even if you don't get fully trained in a CBT-i protocol. This is something that I teach clinicians to do. If you learn some of those CBT-i principles, they're quite simple, but they have a significant impact on your patient's experience of sleep, as you can see here. And there's some references there if you want to take a closer look. Now, what is CBT-i? CBT-i is much more than sleep hygiene. A misnomer I hear a lot is that sleep hygiene is equivalent to CBT-i, but they're actually different. Sleep hygiene is kind of like dental hygiene, right? So you brush your teeth, you floss. That's a good way to keep your teeth healthy. But if you have a cavity, dental hygiene is not enough to take care of it. Sleep hygiene is like that. It's a way to keep your sleep healthy, but it's not enough if your patient is dealing with chronic insomnia. Then we need a more robust for that. So sleep hygiene is an aspect of CBT-i. What this slide is showing you is the different components of CBT-i and which ones are most effective Are there any that are not as effective? And are there any components that are potentially harm? This was published in JAMA Psychiatry in 2024. And what you might find interesting here is I'm just going to jump down to the potentially harmful section. Waiting for treatment, okay, that kind of makes sense, right? If you're not getting treatment, then your insomnia could get worse. But relaxation procedures are in the potentially harmful category. Anyone know why that might be? Any guesses? Feel free to share that in the comments. I'm going to explain why that is in a minute. I'll go to this section here. The not so beneficial aspects are sleep hygiene education. So studies do show that if you have a patient with insomnia and you're giving them information on sleep hygiene, it's actually not shown to be all that helpful, whereas CBT-i is. Automated encouragement, so sending them text messages and things like this between sessions, maybe not so beneficial. In the beneficial category, these are some of the core components of CBT-i. Cognitive restructuring is one of them. So that is addressing the unhelpful thoughts that might feed into the patient's insomnia. So some of those unhelpful thoughts might be things like, I have to get 8 hours of sleep every night in order to function, or I can't sleep without melatonin, these kinds of things. Sleep restriction refers to restricting the amount of time they're spending in bed so that they're filling up that time with sleep. You'll often find that patients with insomnia spend more time in bed hoping they're going to get more sleep, but that actually becomes counterproductive. If we have time later, I can explain that in a bit more detail. Stimulus control is using the bed for sleep only. So they shouldn't be working in the bed. That's not the time to be lying around watching TV, eating snacks, things like this. Keeping the bed for sleep and intimacy only. Third wave components are shown to be beneficial. So these are things like ACT, which is acceptance and commitment therapy, mindfulness practices. And this is something that we use in my practice as well. We blend those third wave components with CBT-i. And then in-person delivery is shown to be effective, but so is digital delivery. So virtual CBT-i is also quite effective. Okay, so potentially harmful, and I see a comment here, relaxation doesn't target the core mechanism driving chronic insomnia. Yes, okay, excellent. So why are those relaxation procedures potentially harmful? Yes, it doesn't target that core mechanism. And what often happens when patients are struggling with insomnia, what do? They try harder to fall asleep. So now they're doing these relaxation procedures like, like a progressive muscle relaxation or maybe listening to a guided meditation. They're doing that with an attachment to the outcome that it's going to make them fall asleep. So now it becomes a form of effort. Well, I did that meditation and I was still awake. It didn't work. Do you ever hear that from your patients? I hear that a lot. I did that headspace meditation. It didn't work. Well, the idea with relaxation is that it's not supposed to make you fall asleep. The idea is to help you relax. But oftentimes patients with insomnia, they're doing it with that effort. And what we want to do is help take away that attachment to the outcome. Sleep, there's this quote that I love, which goes, sleep is like a cat. It only comes to you when you ignore it. So the harder you try to sleep, the more elusive it becomes. So that's why the relaxation procedures can be potentially harmful. It doesn't mean don't use them, but we have to talk to our patients about how they're using them and what the expectation is around them. And I see a question about CBT-i online platforms. Great. Yes, let me share a couple, and then if we have more time at the end, we can go into that. So there's a few different options. There are online clinics. Some of them do take insurance. One of them is called Dr. Lullaby, and the other one is called Moona, Moona, Moona Health. Those are both insurance-based virtual CBT-i clinics. There are apps. One of them is called Sleep Reset. Another one is called Stellar Sleep. Those are CBT-i apps, also research-backed. Some of them do take insurance as well. And then there are lots of independent CBT-i practitioners out there. My clinic is one of them. We don't take insurance, but some of them will, and some of them will be private pay. And so that depends on what your patient needs. And many of those you can find on the Behavioral Sleep Medicine directory. So hopefully that was helpful, Victoria, and I can share more later if needed. Okay. How many of you see restless leg syndrome in your practice? You can tell me in the chat if you ever see this. Restless leg syndrome is, I think, under-recognized, especially when it comes to insomnia, because it can look like sleep onset insomnia. It's defined as an urge to move the legs with uncomfortable sensations. So, what you'll hear from patients is that it's hard to get comfortable in the bed. They might describe trouble falling asleep, but if you ask them a little bit more about what that looks like, they'll say that they feel like they need to move their legs or wiggle their toes, or that they have pins and needles in their legs or creepy crawly sensations. This is alleviated by movement. So if they get up and walk around, it alleviates it. And as soon as they go back to rest, it gets worse again. There's usually a circadian pattern to it. So they'll say it comes on like clockwork at 8 p.m. or 9 p.m. Um, and it can also involve other areas of the body. So sometimes it can involve the trunk or the arms, but most commonly it's in the legs. It's twice as common in women than it is in men, and it peaks during pregnancy, especially in the third trimester and during menopause. So that may be because of hormonal fluctuations, but RLS is also driven by low iron. And so that's related to dopaminergic dysfunction in the central nervous system, and iron is a cofactor for dopamine synthesis. So there is an interplay between iron deficiency in the brain and central nervous system and estrogen. So the diagnosis is clinical. You don't need a sleep study to diagnose it. So it's based on clinical history. And these are the 5 criteria. So an urge to move the legs, it's worse at rest. There's relief with movement. There's that evening or nighttime pattern. And you're excluding other causes of leg discomfort, like leg cramps, neuropathies, and things like this. It looks like sleep onset issues, and it can be quite debilitating for people. Patients will say like they feel like they're jumping out of their skin. It's so uncomfortable for folks. So there's an increased risk of anxiety and depression and impaired quality of life. Okay, so what's really important to highlight here is that iron deficiency piece. So with iron deficiency, we're specifically talking about ferritin, and the ferritin that we're going for, the optimal ferritin level is 100. So that's a lot higher. I was speaking to a colleague about this yesterday, and he was like, 100, we're looking for ferritins. Look, when I'm doing ferritins with women, I'm often finding ferritins of like 25, 30, but our optimal level is 100. We're going to talk about that in a little bit more detail when we get to the lab section here. But that's another thing I want you to be keeping in mind. So if you are seeing women with this type of clinical picture, even if they have restless sleep without a full meeting the full criteria for restless leg, check their iron levels, and you may be surprised by what you find. So we'll come back to that in a minute. So the diagnosis is based on clinical history. The American Academy of Sleep Medicine recommends these serum iron studies, so checking a ferritin, transferrin saturation, serum iron, and CBC. It should be done fasting in the morning. You want to withhold iron supplements and iron-rich foods for at least 24 hours. I usually hold for 48 hours. Make sure they're not having a large steak dinner or something like that the night before, so they're not getting a big iron load. And the iron supplementation is recommended if ferritin is less than 75, but there's actually new guidelines now suggesting you supplement if it's less than 100, or the transferrin saturation is less than 20%. And again, we want to be looking at other causes of RLS like renal dysfunction, pregnancy status, and things like this. Another big takeaway with RLS is that dopamine agonists are no longer recommended for first-line treatment. So like Mirapex, for example, no longer recommended for first-line treatment because of the risk of augmentation, where it makes the symptoms worse over time. So the first-line treatment is getting that ferritin level up. So using iron supplementation in oral form or iron infusions. And then there's other medications that are recommended outside of today's scope. But I wanted to introduce that concept for any of you seeing RLS in your clinic. Okay, so let's talk about obstructive sleep apnea. Are any of you seeing that in your clinic? Obstructive sleep apnea, as I mentioned earlier, it shows up very differently in women. So I want you to have this on your radar as well. So remember that framework: symptoms, workup, treatment. So if a woman comes to you with sleep issues, whether it's sleep onset or sleep maintenance issues, let's think about that workup. Let's get that iron workup done, assess for RLS, and let's also assess for obstructive sleep apnea. So in women, it's not always related to weight. So this is true in men as well. So I had some hesitation there. So in sleep apnea can show up in people of all different shapes, all different sizes, all different genders. Like it can show up in all different kinds of people, ages. You can see it in children, um, young adults, older adults, all kinds of people. And in women, it doesn't always look like the loud snoring, the gasping arousals, the partner who's elbowing them in the middle of the night because they stopped breathing. This can look like depression. It can look like fatigue. It can look like morning headaches. It can look like insomnia, particularly sleep maintenance insomnia. And in women, you'll less commonly see snoring and the witness apneas and the excessive daytime sleepiness. Women are often misdiagnosed with having treatment-resistant depression, fibromyalgia, chronic pain. I see women with chronic headaches that are intractable to treatment. You'll also want to be on the lookout for this in patients with hypertension. These are all signs of a sleep apnea. So it might not look like the classic symptoms at all. It can happen in petite people, thin people, athletic people. So body habitus is not necessarily a sign at all. Now, why is it more common in, or why is it like this in women? Well, women have a shorter upper airway. There's more airway collapsibility in women. And especially after menopause, because of those hormonal shifts. Remember, we talked about progesterone being a respiratory stimulant. Because of that reduction, you get more collapsibility of the airway. So we see that increase in sleep apnea after menopause. So these are some of the other factors that feed into OSA. So what obstructive sleep apnea is, I'll maybe just define it if anyone's not familiar. It's when you get periods of uh, a reduction or cessation of breathing during sleep. So you'll either get these 10-second periods where there's no airflow, or you'll have a 10-second period where there is a reduction in airflow. And that can happen multiple times an hour. And those can be associated with intermittent hypoxia. So you get a reduction in oxygen levels. You get CNS arousal. So now the body interprets that as this stress. So it's hard to maintain sleep because you're not getting into deep sleep. Your brain is waking you up because you're not getting enough oxygen. You're not breathing properly. That leads to sleep fragmentation. And then that cycle continues. And so that leads to changes in lifestyle. So decreased quality of life, increased medical expenses. You get the poor sleep, daytime fatigue, insomnia. There's also a public health issue related to increased risk of workplace accidents and automobile accidents. And then in terms of health issues, there's an increased risk of stroke, hypertension, coronary artery disease, metabolic diseases, cardiac arrhythmias, cognitive impairment, and so on because of untreated sleep apnea. So this is why it's so important to recognize. Now, in terms of the criteria is based on AHI, which is the apnea hypopnea index. So an AHI more than 5 meets criteria for sleep apnea. A level of 5 to 15 meets criteria for mild sleep apnea. 15 to 30 is moderate. And then a level of over 30 is severe sleep apnea. Now look at this. Excuse me. Okay. Look at this graph explaining the prevalence of OSA in women by menopausal status. So the orange box represents postmenopausal women. So look how that prevalence doubles after menopause, right? And this is for any level of OSA, so mild and onward. And then for moderate obstructive sleep apnea, 29% in this study had moderate sleep apnea. And again, I'm just really emphasizing this because it's something that is often missed. So have a really low threshold. to test for sleep apnea in women who are struggling with sleep, particularly sleep maintenance issues, especially if they're going through perimenopause or they're postmenopausal. The other little key clinical pearl I want to share with you is that one sleep study doesn't necessarily rule out sleep apnea. So I'll have patients come to me saying, well, I had a sleep study and it was negative, or I had a sleep study 5 years ago and it was negative. One sleep study is kind of like getting one blood pressure reading. It's assessing what was going on at that time, but sleep apnea can fluctuate from night to night. And women often have milder sleep apnea by this criteria because this criteria was based on symptoms in men. So women often have milder symptoms, or a milder criteria that may have been missed on one study. So I often will get more than one study or do longitudinal testing, where we're doing multi-night studies in women to see what's really going on with their sleep. Are any of you doing sleep studies in women with sleep issues? Tell me in the chat if you're already doing this. We can talk more later if we have time during the Q&A about resources for this as well. I'm going to I'll just talk very briefly about this. So these are some different methods to identify obstructive sleep apnea. A couple things I want to point out. One is the stop bang questionnaire. So this is a commonly used validated screening tool to assess for sleep apnea in the clinical setting. In women, you'll often see that they get a score of like 0 or 1. Because the symptoms are based on snoring, excessive daytime sleepiness, neck size, obesity, all of those things that we just talked about don't necessarily determine whether someone has it or not. So I'll have women who fill this out and they have a score of 1, yet they have severe sleep apnea that was never tested for. So you don't want to be going by the stop bang questionnaire alone. The other thing I want to point out is that home sleep testing, while it's much more accessible these days, it may not be sensitive enough for people who have milder symptoms. So if your patient does get a home sleep test and it's negative, but they're still having symptoms, you still suspect it, you may want to do multi-night testing or send them for an in-lab sleep study that's a lot more sensitive. And again, I can share more about that later if anyone has questions. Okay, so do you remember the hypnogram that we looked at earlier? So the hypnogram was that representation of our sleep architecture across the night. This is a hypnogram from a woman at baseline and then 6 years later when she was perimenopausal. So this is premenopausal and perimenopausal. What do you see here? What jumps out at you right away with this hypnogram? Premenopause, so we see that cycling of her sleep, the deep sleep here, the REM periods getting longer later in the night, and then some awakenings. In the perimenopausal hypnogram, look at all of this. Look at all the sleep disruption. All of these awakenings. There's even some REM disruption there. Look at that. See how fragmented that is. So I just wanted to show you that as a visual so you can see what many of our patients or even yourselves may be experiencing during this perimenopausal time. Now, those sleep disruptions in perimenopause are not just related to vasomotor symptoms. Oftentimes they are attributed to that. Even physicians, I was in a conference a few weeks ago and someone did a survey asking physicians, what do you think is the number one complaint of women in perimenopause with regards to sleep? And they were saying vasomotor symptoms. But actually the number one complaint is that sleep fragmentation that we just looked at. And that can be because of multiple different factors, including vasomotor symptoms, but also some of those more general changes in the hormonal milieu that we just talked about, sleep changes related to aging, comorbidities. We looked at some of the primary sleep disorders like sleep disordered breathing, restless leg syndrome, periodic limb movement disorder. We talked a bit about socioeconomic and work-related factors, psychosocial factors, depressive and mental health symptoms, and so on. So there's all these different factors. So again, when you're working with somebody who's experiencing sleep issues during perimenopause, you can even save this slide and go through this kind of checklist in your mind to see what might be contributing, because everybody's unique and they have their own unique biology that we want to take into account. Okay, so I'm not going to spend too much time on basic screening labs here. We've talked about them a little bit. We did talk about the ferritin and the iron studies. But some of the other labs that I like to get in patients are a CBC, a CMP, hemoglobin A1C. I just want to kind of see what's going on metabolically with them. Thyroid issues, of course, can contribute to sleep problems. And then I also like to get vitamin D, B12, and folate in those patients, and then a lipid panel as well. And one of the reasons I like to get those vitamins is that, again, in women, I'll often find that they have a suboptimal vitamin D level, suboptimal B12 level, and those things can contribute not only to fatigue, but there's also some data supporting that those suboptimal levels can contribute to sleep fragmentation uh, and and poor quality sleep. So from a holistic integrative standpoint, I like to understand what's going on from a nutritional perspective, make sure all those micronutrients are optimized, and then kind of looking medically at what else might be contributing. So let's shift gears a little bit and talk about some integrative strategies. So in conventional sleep medicine, we've got pharmacology, CBT-i, which we looked at, PAP therapy, which is positive airway pressure, like CPAP for sleep apnea, and sleep studies, which we looked at as well. In integrative medicine, we've got all of those, plus we've got lifestyle medicine, we've got those third wave therapies like ACT and mindfulness, we've got mind-body practices, nutrition, herbs and botanicals, circadian regulation, connection and purpose is a big one that's often missed when it comes to sleep, and pharmacology as well. Now, today's World Sleep Day, so this is from the World Sleep Society. This is a 10-step process for sleep hygiene. Um, I won't read all of these right now, but you can take a look at this, and this will be posted later as well, so you can take a closer look. Okay, so I just wanted to talk for a few minutes about melatonin. Many of our patients are taking melatonin. Tell me in the comments if your patients are taking melatonin as well. It is one of the most common supplements that you'll find adults in the US taking. So melatonin does much more than impact sleep. It is a hormone and it has multiple physiological functions. It's got antioxidant functions, it's got anti-inflammatory functions, um, which are outside today's scope. But it's really interesting because it's being studied for things like inflammatory bowel disease, cancer, and things like this. But in terms of sleep, melatonin is the major chronobiotic hormone that regulates the circadian rhythm. So how might we consider using it in our female patients? Well, melatonin secretion, so it's secreted by the pineal gland in the brain. It's also produced in the gut. That pineal secretion decreases with age. Menopause is also associated with a significant reduction in melatonin levels. So that may be age-related, but also potentially hormonally mediated. And that affects sleep patterns. So you can consider it in your perimenopausal and menopausal patients in a dose of about zero point 0.3 up to 3 milligrams about an hour or two before bedtime. And that can support their sleep. I don't present it as a sleep aid. So if patients are struggling with insomnia, we need to set expectations that this is not something you're going to take and now have a great night's sleep or it's going to solve your insomnia. It doesn't work like that, but it does work as a support. And it may also help with vasomotor symptoms. There were some studies recently looking at melatonin quality when bought over the counter. So we want to be really mindful about using a good quality professional grade supplement. Some of those you can find over the counter, but you want to make sure that it is a third-party tested supplement. And all that means is that it's been tested to determine that what's in the supplement matches what it says on the label. If any of you use melatonin, please share that in the chat as well. So let me just, yeah, I'll just speak another minute or two about the melatonin. Melatonin is a circadian regulator, so you can also consider it in your younger patients. So if you are working with people who are more of a night owl chronotype, so that you'll see more commonly in your teenagers, your young adults, you can use melatonin to shift the circadian rhythm. So it is not a treatment for insomnia, but it is a circadian modulator. So it helps to regulate that sleep-wake cycle, and then it can be a support for those patients who have that reduction in melatonin secretion. And I see a comment, I have nightmares when I take melatonin. Yes, okay, that's such a great point. So nightmares are a common side effect of melatonin, nightmares and vivid dreams. You could try using one of those third-party tested supplements with your patients if they do complain of those side effects. See if that helps. You could try using a lower dose if melatonin is indicated for them. But for some people, that is a intolerable side effect, so we won't use it. The other side effect to look out for is daytime grogginess. So you might find that patients complain of feeling more fatigued the next day or more groggy. I'm personally someone who's really sensitive to melatonin. I get vivid dreams and I feel really groggy the next day when I take it. So just be on the lookout for that. I've also seen patients develop kind of a low-grade insidious depression when they take melatonin every day. I've had this come up a few times in my practice where I've had patients who were taking melatonin every day for years on end, and they had this depression that just wasn't getting better. And once we started weaning them off that melatonin, their mood started to lift. So just a little, that's more anecdotal, just based on my experience. Just a pearl for you to be on the lookout for. So melatonin is a tool. When I use it with patients, I'm usually not having them take it indefinitely. Generally, I'm using it for about 8 to 12 week periods of time for support. Then we take a break and reassess. Now, a note about hormone replacement therapy, because of course, a talk on women's sleep is not going to be complete without that. Um, Disclaimer, I'm not trained in HRT, so for those of you who are trained, you probably know more about this than I do. But I'll just speak about it for a moment. So menopausal hormonal therapy is shown to improve the quality of sleep in women, and it often improves those vasomotor symptoms that disrupt sleep. We talked a little bit about the anxiolytic and calming effects of progesterone. And one of the reasons for that is that it stimulates the GABA receptors, GABA being an inhibitory neurotransmitter. Estrogen can help to improve sleep architecture by increasing REM sleep, total sleep time, decreasing the time to fall asleep. And it also has that thermoregulatory effect. So it helps to regulate that core body temperature. I will say about this, though, that I have had lots of patients come to me for treatment-resistant insomnia and sleep issues who are already on HRT. So it's not a magic treatment. So we need to be really mindful about, again, the expectations that we're setting with patients. So HRT can be a support for patients, but it's not necessarily going to treat their sleep apnea. It's not going to treat their chronic insomnia. It can help. And there are some women who start HRT for sleep issues and it works great and that's fantastic. But I see the population where they've started it and it's still not helping. So that's where we implement all the other things that we talked about today. So if you have a woman who's on HRT, she's still experiencing sleep issues, then consider referring to a sleep specialist for further evaluation or start implementing some of the other tools that we just looked at. Okay, so I want to give you a framework to leave with so that with your next patient or client, you'll know how to work through and make sense of all this information that we just covered. And this framework is called the CSH framework. This is a framework that I sort of named and use in my practice. C stands for circadian rhythm, S stands for sleep drive, and H stands for hyperarousal. And you can think of those as the three legs of a stool. So we need all three legs to be intact for that good quality sleep to happen. The floor under the stool is lifestyle. So let me explain the C and the S components first. C is circadian rhythm. So that's your body clock. That is your alertness signal. In the morning, here's the days down below, so the timing, so 7 a.m. to 11 p.m. So that's one day, and then here's the next day, 7 a.m. to 11 p.m., and so on. So the circadian rhythm is your alertness signal that increases as the day goes on, and then the alertness signal goes down at night. The sleep drive is kind of like hunger. So the longer you go without eating, the hungrier you are. Sleep drive is like this. The longer you go without sleeping, the sleepier you will be. So that sleep drive builds up as the day goes on, kind of like this shark's fin shape that you see here. So when that sleep drive reaches a peak and that circadian alertness signal goes down, that opens up the sleep gate. And that's when you get this nice wedge of sleep. So you can imagine if your patient's circadian rhythm, if their body clock is all over the place, They're getting up and going to bed at different times every day. Maybe they're a shift worker, or maybe they're just doing that behaviorally. They're eating their meals at different times every day. There's not a lot of regularity to their day-to-day routines. The circadian rhythm is going to be kind of all over the place. It's not going to line up nicely with that sleep drive to get that nice wedge of sleep. Similarly, if your patient is sedentary, they're laying around in bed a lot, they're spending too much time in bed, or I had a patient who he worked from home remotely on his computer. He's on his computer all day, sitting at a desk. As soon as he finished his work, he'd get into bed and he'd watch TV in bed for the rest of the night. So not a lot of activity. He had insomnia, unsurprisingly, because his sleep drive just wasn't robust enough. So if your sleep drive isn't robust or circadian rhythm is irregular, you're not going to get this wedge of sleep. So you want to be assessing those two aspects. The third leg of the stool was hyperarousal. So, oh, I see a typo there. I'll fix that later. But that's when your nervous system is stuck in go mode. So this is your patient who's wired but tired. They've got those elevated levels of cortisol and adrenaline. Sleep feels impossible. Even when they're tired, they're like, this is your patient says, like, I'm exhausted, but I can't sleep. This cycle feeds into itself because this is the patient who's trying harder. They're doing more things to calm down, but that actually revs up the nervous system. So that's another area that you want to assess for. Now, this hyperarousal, it's not just stress mediated. It's not just psychological. It can also be exacerbated by restless leg syndrome, by obstructive sleep apnea, by medical issues, thyroid problems, by hypertension, and all of these other things that we've talked about as well. So medical issues also can feed into hyperarousal. Chronic pain as well is another example of that. The floor under that three-legged stool was our lifestyle. So I like to call this the low-hanging fruit. That's how I talk about it with patients. Like, what's the low-hanging fruit that we can start working on? And I like to put the ball in their court because, we can tell our patients all the things to do, and it's not that they don't know what to do. A lot of times they know exactly what they need to do, but we can rather act as a coach so that we can help them identify what's doable for them. What do they want to work on first? Do they want to start cutting down on that extra glass of wine that they might be having at night? Or do they want to work on that irregular sleep schedule? Maybe start to stabilize that a bit more. Or do they want to start with getting a bit more movement or exercise during the day? So here's where we can act as a coach and help them figure out what the low-hanging fruit is for them, and then give them a plan to do that. So there's lots of different ideas here that you can take a look at. So putting this all together, how do we make sense of all of this? So when you work with your next patient who has sleep issues, a good place to start is with looking at getting curious about the diagnosis and the root causes, symptoms, workup, treatment. Is there restless leg syndrome? Do they have an iron deficiency? Could this be sleep apnea? What else might be at play that's contributing to this insomnia picture? Then we want to provide some psychoeducation on sleep so that the CSH framework is a great one to share with patients. It's easy to understand, it's tangible for them. They like the three-legged stool analogy. That's what I use in my practice. So just telling them a bit about how sleep works, showing them the hypnogram, that it's normal to wake up at night. All of these things can go a long way. Then you can collaborate with them on some integrative strategies, work on that low-hanging fruit. Do we need to do a sleep study? Should we work on some circadian regulation? So you make that a collaborative process. Then you track their progress and adjust as needed. Sleep is not going to improve overnight. It can take 6, 8, 10 weeks of consistent changes for them to start to notice those benefits. Sometimes it doesn't take that long. I'll have patients tell me within a week or two they start feeling better. But an analogy that I use with patients is that it's like turning around a big cruise ship. So we might make 1 or 2 changes and it feels like it's not really doing anything, but over time you're going to be going in a completely different direction. It's not like a speedboat. So setting expectations with regards to sleep is really, really helpful and important. So we don't overhaul everything at once. We start with the low-hanging fruit, get your patient's buy-in, watch out for rigidity about sleep hygiene or very strict routines that can create more hyperarousal and anxiety around sleep. We want to promote relaxation, not force sleep or sedation, and normalize those sleep changes across the lifespan. So sleep disorders are common in women We want to treat the underlying cause by getting the diagnosis right. Consider additional workup with lab testing and sleep studies. We can use lifestyle and CBT-i. Supplements are a support but not a solution. And then you can use HRT if that's something you're trained in or refer out when appropriate. So today we covered what normal sleep looks like in women, how sleep changes through the lifespan. We looked at some of the common sleep disorders likely to show up in your practice. We looked at some lab testing and clinical pearls and how to think through sleep complaints in women. And I think we're just on time. There's some questions. Thank you for your attention today. You can find me at all of these different places there listed. And okay, great. And I see a great question. I think that I'll just take a moment to answer that if that's okay, Victoria. Should I just jump in?
Yes, absolutely, please.
Okay, wonderful. So the question is, can you discuss the challenge of non-restorative sleep, individuals who can fall asleep and remain asleep with no problem, but still don't wake up refreshed? Yes, excellent question. Okay, so this is where we want to go back to the diagnosis. What might be causing that? So they're falling asleep and staying asleep, but they're not waking up refreshed. So things I'm thinking about are sleep apnea. So they may not even register that they're having those awakenings during the night, right? They may not be aware of it, but it can still be disruptive. So I'm going to be thinking about sleep apnea in a patient like that. Or periodic limb movement disorder, which again can be silent. The patient may not be aware of it, but they may experience unrefreshing sleep. Are they taking naps during the day? What is their Epworth Sleepiness Scale score? That's an easy tool that you can use in your practice. Do they have excessive daytime sleepiness? Could there be something like narcolepsy or hypersomnia condition going on? That's another differential diagnosis. Or is there something nutritionally? Do they have an iron deficiency? Do they have vitamin D, B12 deficiency? Is there something else from a micronutrient or nutritional standpoint that could be contributing? So that's where we want to become like a detective and look at all those different pieces of the puzzle. So in that type of patient, I might get a sleep study just to see what else might be going on. Hopefully that was helpful. If that answered your question, let me know, or if you want me to elaborate further.
All right. I don't see any other questions in the chat. We have about 1 minute left, so that's your golden chance if you want to ask one. Um, but it was amazing. I really enjoyed it. Thank you so much, Dr. Bhopal. We all really fortunate to have you as our speaker and hope to see you back maybe in the future.
Thank you very much.
All right. And thank you for all of you who joined us today. Please be on the lookout for our future events. The next month is Oral Health in Women, and we hope to see you there.